Okay, our next presentation is from Dr. Richard McKeon. Dr. McKeon is currently chief for the Suicide Prevention Branch in the Center for Mental Health Services of the Substance Abuse and Mental Health Services Administration, SAMHSA, where he oversees all branch suicide prevention activities, including the Garrett Lee Smith State Tribal Youth Suicide Prevention, the National Suicide Prevention Lifeline, and the Native Aspirations Program. Thank you.
Thanks. And to advance the slides,
Left and right.
Okay, great. Thank you. Okay, it's a pleasure to be here with you to talk about this incredibly important topic. And as Keita emphasized, you know, that this is obviously a tragic issue for our service members, for our veterans, but it is also a national issue, right? That in 2017, the last year for which we have full data, over 47,000 Americans died by suicide. It's the 10th leading cause of death in the United States. Think about this, it's the second leading cause of death from ages 10 to 39, according to the CDC. Of even greater concern is that suicide in the United States has been increasing. A report by the CDC that came out earlier this year showed that suicide is increasing in 49 of the 50 states, and in half of those states, the increase is greater than 30%. And this is approximately over the last decade. So it's important that we see veteran suicide, and we, of course, have a special responsibility for our veterans, but that we see it in the context of this overall tragic national problem. So let me, and I'm from the Substance Abuse and Mental Health Services Administration, so let me mention a couple of things. According to our data, over 46 million adults in the U.S. report having any mental illness, right, with 11 million having a serious mental illness, okay? Among young adults, both major depressive episodes and serious mental illness have been rising, okay? There are higher rates of suicide, and people with serious depression or psychotic disorders, so mood disorders, psychotic disorders, have a rate that's 25 times that of the general public. And so it's very important for us to pay attention both to the entire context for suicide prevention, but also to the mental health needs. And one thing that's not necessarily well understood, in 2017, the number of suicide deaths in the United States was very close to the number of opioid overdose deaths. There were almost 47,200 suicides and about 47,700 opioid accidental overdose deaths. You may have heard the 70,000 figure, which is accurate. That 70,000 is all overdoses from any substance. But when we look at the magnitude of suicide, it is roughly equivalent to the accidental opioid overdose deaths in terms of numbers in 2017. Now, this shows you some of the data on suicide mortality. Obviously, one of the things that is most obvious is the greater mortality from suicide among men compared to women. Unfortunately, for both men and women, it has been going up. So we do need to pay attention to both, but in terms of where the bulk of the suicides are, I think the ratio now is about 3.5 men for every woman who dies by suicide. This is certainly a priority for SAMHSA's leadership. Under the Cures Act, for the first time, there was established the position of Assistant Secretary for Mental Health and Substance Use. Dr. Eleanor McCants-Katz is the first person in that position. And so part of SAMHSA's strategic planning incorporates these issues. The Cures Act also called for the development of an interdepartmental serious mental illness coordinating committee, and part of the key recommendations for that are around improving suicide prevention, also about improving crisis care in the United States. And you know, there are a number of things that are particularly important as part of a crisis system. having someone to talk to who can follow up with you, and a place that you can go when you need help, and someone who can respond to you potentially at your home, referred to as mobile response or crisis response. Let me give you an overview of SAMHSA's initiatives before I talk specifically about some of our partnerships with the Veterans Administration. So since 2005, after Congress passed the Garrett Lee Smith Memorial Act, SAMHSA has been making grants to states and tribes around youth suicide prevention. All 50 states at one time or another have gotten these grants. All 50 states don't have them at any given point in time. But one thing that's really important to know is that our evaluation of these efforts have shown that counties that are implementing Garrett Lee Smith activities have lower youth suicide rates and rates of youth suicide attempts than matched counties who are not. So that is, that is very encouraging. Unfortunately, when we look closer at the data, what we see is that in the counties that are implementing the youth suicide prevention activities, basically suicide is staying flat. And in the other counties, it's going up significantly. So that's where so it's like we're kind of battling youth suicide to a draw, almost. So while these are very encouraging results in some ways, they also show that there's a lot of work that we need to do. SAMHSA has also, since 2005, had a campus suicide prevention program that makes awards to community colleges, public universities, private universities around the country, focusing on mental health promotion and suicide prevention. More recently, we have been working with funding provided by Congress on adult suicide prevention. Garrett Lee Smith grants are by statute up to age 24. And so there we have what we call the Zero Suicide Initiative, which is working to strengthening suicide prevention within healthcare systems. Okay, and that's particularly important, right? Because we've learned a lot about how to help people who are suicidal. But we need in our healthcare systems for everyone to be aware of the work that's been done and to do it more systematically. That's what the Zero Suicide Initiative is designed to do, is to make suicide prevention central within healthcare. But it's also important to be aware that that's not the only part to suicide prevention. What's needed is a comprehensive public health approach. That's what we do in our youth suicide prevention grants. Because if we try to wait for people at risk to come to the offices of clinical psychologists such as myself, we're not going to accomplish what we need to do, which is to finally stop the tragic increase in suicide and begin to drive it down across the country. SAMHSA also funds the Suicide Prevention Resource Center, probably the best single collection of resources on that website that's found anywhere in the country. We're doing a lot of work on tribal behavioral health. Our Native Connections grants now go to over 140 tribes and tribal organizations across the country, focusing on preventing suicide and preventing substance abuse. And then we also have the National Suicide Prevention Lifeline. Last year, in calendar year 2018, over 2.2 million calls were answered by the National Suicide Prevention Lifeline. It's a network of 163 crisis centers across the United States. So these are your local community crisis centers that are in your districts that are working on this, networked using the number 1-800-273-TALK. I should mention that SAMHSA is currently working on, Congress passed and the President signed into law in August, the National Suicide Hotline Improvement Act. We are working on a report for the FCC, as is VA. We have a February deadline to them regarding the potential impact and advisability of a national 3-digit N11 number for suicide prevention and crisis intervention. And then FCC has 6 months to then make a report back to the Congress on that. Now, since 2007, SAMHSA's had a relationship with the Veterans Administration so that when somebody calls the Lifeline number, if you press 1, you are connected to the Veterans Crisis Line. About a third of those 2.2 million calls go to the Veterans Crisis Line. And VA has made a tremendous effort to build up the strength of those crisis centers. They now have 3, Canandaigua, New York, Atlanta, Georgia, Topeka, Kansas, to answer those calls. The other 2/3 where people don't press 1 get answered by your local crisis centers. Now, one other area that we are working closely with the VA on is we also have called the Service Member Veterans and Their Families Technical Assistance Center. And this is working together for VA and SAMHSA and HHS more generally and Department of Defense to try to reach veteran service members and their families, particularly those veterans who are not in VA care, who are on average 14 of the suicides each day. We all have a responsibility to be trying to work together to prevent suicide among those veterans. And so this is what this TA Center tries to assist with. And Keita mentioned the Mayor's Challenge. This is actually a slightly over older side because it doesn't have the 3 most recent ones added to it, but it gives you a sense of some of the locations participating in the Mayor's Challenge. And again, this is the idea that there needs to be a comprehensive public health approach that that involves a variety of people, workplaces, healthcare organizations, and members of the community of all kinds to work together to prevent suicide. So we're very excited about this work. That started last year. This year, we started work on what are called the Governor's Challenges. These are the 7 states that are engaged in that: Arizona, Colorado, Kansas, Montana, New Hampshire, Texas, and Virginia. SAMHSA also provides additional support to states around suicide prevention. We try to provide support to state suicide prevention coordinators who are typically part of the state government, many of whom have done great things to try to promote suicide prevention in their state. But we all have to work together on this. Let me mention one other piece. I used to run a psychiatric emergency service and a hospital-based community mental health center in New Jersey. So I'm particularly, interested in the importance of crisis work and crisis intervention. It's got a little bit of a wonky title, the Crisis Intercept Mapping Initiative. But here's the idea. The idea is that we know that veterans who are in crisis, right, hopefully they're contacting the Veterans Crisis Line, but many are interfacing with community emergency and crisis services. And so what we're trying to do is to help make sure that those veterans get the care they need. If they, for example, go to a community emergency room, in New Jersey, when I was there, there were 2 VA hospitals. But if a veteran was brought to an emergency room, if they weren't in the 2 counties where the 2 VA hospitals were, they would be brought to a local community emergency room. It's important that all of those community emergency rooms have protocols for providing follow-up for them. And there's a particular reason, for that, and for work being done on services. I'm just about out of time, but let me emphasize the idea that care transitions are critical for suicide prevention. We could all wish that when somebody left an inpatient unit or an emergency room that they had no suicide risk. That's not the case. Rather, these are times of high risk. And we need to be able to connect with veterans and other Americans in those circumstances in an ongoing basis. This is some of the strongest research in suicide prevention has shown that if we do this, we reduce suicidal behavior. It has the potential for preventing deaths, injuries, and readmissions. So because the Action Alliance is doing work on this, the point of this slide is just to say, at a time when we can send a package halfway around the world and track it, we should not be losing veterans and other Americans within the gaps of our systems. So because this is not the floor of the House of Representatives and the Senate, and I can't ask one of my colleagues to yield me additional time, I will stop there.